So yeah, welcome tonight to the third event. Tonight is the knee event, celebrating Victoria House's 30-year anniversary. So tonight we're very privileged to have three expert panelists joining me tonight. We've got Associate Professor Julian Freitag. Julian is an experienced musculoskeletal physician and a fellow of the Australian College of Sports and Exercise Physicians. His practice is focused on active management of musculoskeletal conditions, including osteoarthritis and tendinopathy. Julian has a connection with La Trobe University and undertakes clinical research in regenerative musculoskeletal medicine, including biological techniques and PRP. He's published numerous articles in this area and is a frequent contributor and speaks at local and international conferences. He's worked exclusively within professional sporting teams, worked at both VFL and AFL levels. He's also got a big focus with cycling and is involved with the UCI World Cup events. Mr Tim Lording is a local orthopaedic surgeon who specialises in knee surgery. He works at the Avenue and Glenferrie private hospitals as part of the Melbourne Orthopaedic Group and has a public appointment at the Alfred Hospital. He's got a particular interest in knee instability and dislocation and is a member of the International ACL Study Group. He's heavily involved at a local level where he serves as the Victorian Scientific Secretary for the Australian Orthopaedic Association. Associate Professor Jane Rooney is a specialist sports physician with a subspecialty in knee. She is a titled musculoskeletal physiotherapist. She's got a particular interest in ACL injury and rehabilitation prevention programs, patellar instability and pain, in addition to knee osteoarthritis management. She was awarded the prestigious Churchill Fellowship in 2017 and was able to travel to Europe, Scandinavia and America looking at ACL injury management programs. She also has a clinical professorship at Swinburne University and is also associated with Melbourne University, La Trobe University, and is also an examiner of the Australian College of Physiotherapists and a regular presenter for many APA courses. So, first of all, we're going to begin with a very brief overview of the radiology that is available to you. So, X-ray is still the mainstay, even though there are more exciting modalities. X-ray gives us an excellent overview as to bone and joint alignment. It's also important that X-ray can be done in a weight-bearing setting to look at the alignment. Is there varus or valgus alignment? We're also able to assess for joint effusion, calcified or ossified bodies. Ultrasound is a very good modality. It enables us to look at superficial structures, in particular tendons, but we can also look at cysts and nerves, and we can also have a functional assessment. Around the knee, it's particularly good for the patellar tendon and hamstring tendons, as I've described. But with ultrasound, we cannot assess internal structures, so we cannot assess ACL stability or meniscal tears adequately with ultrasound. And there are specific Medicare indications that must be on the referral for the patient to claim the rebate, and the government and Medicare have specified them, but they're all pretty logical. They are superficial structures. MRI is more our gold standard for internal structures. So MRI has the best soft tissue contrast resolution. We're able to differentiate cartilage lining the joint from the meniscus. We're able to properly see the ACL, PCL, have a look at the collateral ligaments and other structures, and it gives a good overview. As far as GPs are concerned, there are specific Medicare indications in patients under the age of 50. There has to be the setting of trauma and either a clinical concern regarding ACL tear or meniscal tear. CT has specific indications and is really used either for detecting an occult fracture or for characterisation of fracture. We can also do measurements to assess for patellofemoral joint alignment, and we also, with our CT, can do 4D CT to look at patellofemoral instability. Nuclear medicine and CT SPECT is a functional test, so we're injecting radioactive tracer that goes to osteoblasts and shows us where there is increased activity. It's best looking at complications of joint replacements or looking at bone lesions. We can also look to see, is this a focal process in the knee, or is this part of a diffuse multifocal process in the body? As far as intervention, our main intervention is with ultrasound around the knee. We can do most things at the knee with ultrasound. We can aspirate and we can inject different agents. So we'll move to case one. Case one, Pam is a 30-year-old healthy architect who's about to get married. She's had an acute twisting injury playing soccer on the weekend, and she's collapsed to the ground trying to evade a tackle. She's carried off the field. She comes to see you on Monday and she describes diffuse knee pain. She's got a moderate effusion, which is clinically visible. So I might pass the microphone over to Tim and just ask this question of you. So what are the possible causes of Pam's knee pain?
Is that on? Yep. So from the injury mechanism, which is a sort of a non-contact pivoting injury during sports, the hierarchy of things I'd be thinking of would be, first of all, ACL injury in Australia. That's very common, and that's the typical mechanism. The second thing, most common thing, I think, would be a meniscal tear or meniscal injury, also from that sort of twisting mechanism.
Yes.
Other things would be further down the list, and they would include something like a patellofemoral episode of instability with immediate relocation, or even some sort of osteochondral injury or osteochondral fracture, which may cause. And then way down the list in a 30-year-old would be actual fractures from that mechanism.
Sure. Okay. Are there any specific questions that you would ask in the history?
So specific questions I'd ask in this circumstance would be, number one, did you feel or hear a pop when you had your twisting injury? That's the sort of very typical sort of sounding story for an ACL, but it may also occur in meniscus or patellofemoral instability. I also ask about whether or not they had immediate swelling or slow swelling. Most ACL injuries, because there's quite a lot of blood vessels involved, have pretty rapid swelling, and often they look down and it's already swollen, and I'll tell you that. So that's sort of thinking about those lines. Whereas the swelling associated with a meniscal injury is usually much slower.
Okay.
I want to know whether they can weight bear afterwards. If they're getting up and walking or hobbling off, it's unlikely to be a serious fracture. And also whether or not their knee felt unstable afterwards. They're the main things I'd be looking at.
Sure. Okay. What specific examination findings would you look for?
So I'm basically looking for findings which will either support or refute the differential diagnosis that I've got. Obviously, we've already said that they've got an obvious effusion, so we know that their knee's swollen. But I'd be looking for their range of motion, how much motion they've got, what areas of tenderness around the knee. Are they tender along the joint lines where a meniscus tear we would expect to be tender? And then I'd also be interested in the findings of their ligament examination. Although if you're examining them just a couple of days after, sometimes with the swelling and the stiffness of the tissues, it can be not always easy to elicit a ligament injury at that stage.
Sure. Here's an example of the Lockman's test. Do you want to talk us through the examinations for ACL injury?
Sure. So there have been a number of described sort of tests, and most of them have got different people's names associated with them for ACL injuries. The one that I was taught at medical school was the anterior drawer, which I must say I don't even use at all anymore.
Okay.
I think the two most important tests for ACL instability are the Lockman examination, which is a sort of modified anterior drawer at about 20 to 30 degrees of flexion, and then the pivot shift test, which is a sort of slightly more complicated test looking for the more rotational instability that you get with ACL injury.
Sure. Okay, so here's some diagrams showing you the Lockman's test and the talk about the end point.
Yeah, so it's important with these things to look at, first of all, to compare one knee with the other, because there's quite a wide variation of what's normal. Some people are really, really tight and other people have got quite a dramatic amount of movement, and then you examine the other side, it's the same. But we're very interested in what the end feel is like. So if they've got a moderate amount of movement and then a firm stop, then it's probably going to be okay, and it's probably the same as the other side. But if you pull and there's just this boggy end feel, or you don't get much feeling of something stopping you, then you start thinking maybe the ACL's torn here.
Julian, do you have any comments on examination?
I'd probably very much agree with Tim. I think the difficulty after an injury like this is the examination is sometimes very limited because of the swelling and the pain. So finding out, localising where the tenderness is sometimes gives you an appreciation of, could this be ligamentous, could this be a patellar dislocation? Pivot shift is sometimes, I think, very, very difficult to do, B, pretty difficult to do if the patient's aware of you doing things, because there's a lot of muscular sort of inhibition there. So it's something which we often get a really good result with when the patient's under a GA and a really good appreciation, but in the room's probably really difficult. I'd be sticking to a Lockman's and seeing where that end point is, if it's not too swollen and too stiff.
Sure. Okay. What sort of investigations, if any, would you suggest in this sort of setting?
Look, I think when I see a knee like this, in reality, gold standard is an MRI. It's going to give you a lot of answers, and it's going to show you that internal derangement which you're looking for. You know, if you don't have a history of impact trauma and you're not ultimately concerned about a fracture, look, you can get an X-ray, but ultimately you're going to need to get an MRI in a knee like this with that history. Would you agree, Tim?
Yeah, I agree. I think a lot of patients who have been to emergency department as their first line will have had an X-ray there because they've got access to that.
Mm-hmm.
But most of them who've been to see their GP or another health provider will come with an MRI before they've had an X-ray.
Sure.
X-ray does give you some information, but for this particular injury pattern, I think MRI is going to tell you pretty much everything you need to know.
Sure. Okay. So this patient's had both a X-ray and MRI, and if we go to the X-ray, which hopefully the mouse will come up. Okay, so if you look at the AP X-ray, you can see there is a second avulsion fracture just superior to the head of the fibula along the lateral tibial plateau, and that gives us very high specificity for an ACL injury, but the second avulsion fracture is not always there. The cross-table lateral view, so this is done to try to show a lipohemarthrosis, to show fat layering on top of blood, which would indicate an intra-articular fracture, but we can see there is a large joint effusion there as well. Okay, so now I think the computer's frozen slightly rather than being a pointer, but there's the second avulsion fracture and there is a joint effusion. The MRI image showed a complete ACL tear, an isolated complete ACL tear, and we do know that ACL injuries are associated with other injuries, so there can be injury to MCL and LCL and articular cartilage, and we can show bone contusions. But the key question in this case is, what are the sort of management options for an acute ACL tear? So discussing conservative management and also the issue of ACL reconstruction, and also the issue of prehab. So I'll throw to Jane, and I'll also pass the mic over to you as well.
So obviously there's two main options in this case, isn't there? One is surgical reconstruction of the ACL, using, depends on what graft the surgeon chooses to use, or non-operative management being rehabilitation management. And I use a process with my patients which we like to call patient-centred care or shared decision-making, where patients are given the options of operative and non-operative, and I explain to them the possible advantages and disadvantages of each option, because it's not one size fits all. It depends on the person that you have in front of you. And this girl, from memory, she was a 30-year-old architect, and so it would depend on sort of firstly you want to know the main consequence of ACL ruptures we've talked about is instability. And if somebody has functional instability with daily activities, walking along the road and their knees collapsing underneath them, well, then that makes it a sort of fairly easy decision. If they've done some rehab and their instability is persistent, or they're an elite sports person and they want to get back to sport as quickly as possible. And in fact, even in Scandinavia, where the operative rates are much lower than in Australia, they still refer everybody who wants to return to a pivoting sport for reconstruction. Whereas I would probably have a chat to this girl here because she's a 30-year-old architect, so there's a number of things that you need to consider. If she is functionally stable, as an architect, I would be thinking, well, how much on-site work do you do? Because that's walking on unstable ground, so she needs to be able to have a functionally stable knee for her job. Also, she's 30, she's just got married, so what's her plans? Life plans? She might be wanting to have children and not continue to play sport. Or she might be an avid netballer and is not planning to have children, and then she wants a stable knee to play netball. So it is a difficult, sometimes I spend the whole treatment, the first treatment, actually talking through these options with them, obviously giving them some prehab advice as well, which I'll talk a little bit more about in a minute. But maybe, Tim, do you want to have something
Well,
to say about that?
Jane and I work quite closely together with a lot of patients, so we've got reasonably similar views on this. I think there's no right or wrong answer, and the key is that it's sort of an individualised treatment plan for each patient depending on what they want and what their hopes and aspirations are. And a lot of that comes down to sort of education. So the first thing I try to explain to the patients is that ACL injury causes a spectrum of instability. So some people are so unstable they can barely pick the groceries out of the car and go inside and they fall in a heap, and other people can run and jump and do everything they like as if nothing ever happened. And we don't have any really good way of telling exactly where people are going to end up on that spectrum. Some people we can predict. If you want to play basketball or soccer or Australian rules football, most of those people are going to be unstable, and so most of those people would need a reconstruction. Younger people are much more likely than older people to be unstable, and therefore we'd be sort of erring towards reconstruction in younger people, whereas older people we may be sort of thinking about more conservative. But it really depends a lot on what the patient sort of is aiming to get out of their knee, and as to how we would approach it in the initial stage. And it's important that they understand that the right answer is not the same for everyone, and the right answer is not always immediately apparent. Sometimes they need a bit of time to start getting moving and start getting working before they can make it a good decision about it.
Do you want me to talk about prehab too?
I was just going to pose the next question. Yes.
Okay.
So what are the general principles in PAM's short and long-term management, and what are the benefits of a physiotherapy ACL prehabilitation program?
Okay, well, hang on. There's a few questions here, Andrew. So do you want me to answer all of those? The short and long-term management. So in the short term, obviously, that's different, isn't it? Because you're trying to regain, like if we're talking about whether they end up having surgery or not, ideally, it's been shown in the literature that you actually better surgical results if your knee has good range of movement, minimal swelling, no quad slag and minimal limp with walking before they have the surgery, unless they have the surgery straight off. Do you know, like before the consequences of the ACL rupture has settled into their knee. So normally that would be the goal of a prehab program. There are a few prehab programs that have been published, not many around the world. There's 2 or 3 of them. The main one that I had a look at when I was travelling in Scandinavia is called the NAR program, the Norwegian Active Rehabilitation Program. And it's a fairly intensive 5-week strengthening program. Once those initial impairments or sort of consequences of the ACL rupture has settled, so that they've got good range of movement, no swelling, no limp, then they undertake a strengthening program twice a week. And the outcome of that, they test them at the end of that. They want 80% strength of their quads and hamstrings, and at that point in time they make a decision about if that person is going to continue on in a surgical pathway or a non-surgical pathway. And they've shown that, pre-op quad strength is predictive for up to 2 years post-op. So the stronger you can get before your surgery, the better the post-op outcomes. And also another study showed that people who go into surgery with a worse knee at surgery have worse outcomes with early reconstruction, and they're better off waiting until their knee settles down. They get better outcomes with surgery if they do then need it. So that's the sort of research that certainly, but I've only just started seeing more people for prehab because it's fairly new in Australia. So probably I've been seeing people for prehab since I came back from my Churchill, so probably for the last 18 months. And I think it's gives patients time to consider what their functional knee stability is, because some people think they need surgery, and I keep saying to them, you need surgery for instability, not for pain, not for swelling. Do you know? So sometimes they need to make sure they're making the decision for the correct reason, and that is really functional knee instability.
Sure.
Yeah.
Sure.
Are you trying, as part of the prehab, are you trying to get a better ratio quads to hamstrings to help hold it back?
Yes, to a point. I mean, that's what they were looking at in the Norwegian program. However, to do that, you need patients to be able to undertake an isokinetic test, which is about $250, which we recommend at their return to sport time, but there's not a big appetite to spend a lot of money at this point. So we can get limb symmetry indexes, but not so much ratios, unless people, like obviously my elite and, you know, club sort of players, they'll often get paid by the club to have their isokinetic. Yeah. So then we do look at the ratios.
So that's more of the speed, strength rather than...
Well, we actually look at the isokinetic, we look at the slow, medium and high speed, both quads and hamstrings, and there's actually different ratios at different speeds that we look for. And there's normative data as well. So we look at it and say, what's the... where are they in the percentile for their age and gender matched? So some of my patients might have good limb symmetry indexes, like one AFL draft sort of guy who did his ACL last year. He had only 4% limb symmetry deficit, but he was actually only in the 50th percentile for age and gender. So I'm like, you need to buff up, you know, if you're gonna make it, because really you need to be much stronger. Yeah.
So with your non-elite athletes, you just strengthen them?
Well, I do a strength test on our. We've got some air pressure resistance equipment that we can do quite accurate 1 rep max, 4 rep max, 8 rep max tests. So we can get them a limb symmetry index, but we don't get the ratio as accurately.
So you're just trying to match the other limb, whereas shouldn't you be increasing the hamstrings relative to the quads so that it's supporting that lack of...
Well, yes, we like the quads the hamstring to be about 60%. Well, it depends on the speed, as I said. So, yeah, so it does depend a little bit, yeah.
If we take a sort of surgical approach, so we've made the decision's been made for the surgery to be done.
Mm-hmm.
There's been discussion about different types of grafts being used, such as from the hamstrings, from the patellar tendon, the quadriceps tendon, allograft, all sorts of stuff. Can you just sort of talk us through graft selection?
Sure. So graft selection, again, is a personalised part of the treatment because it's not a one-size-fits-all. Certain grafts each graft has got their advantages and disadvantages. It's a matter of working out which one may be the best for your patient. The hamstrings are the most commonly used graft in Australia, and I think for most recreational athletes, they give a good outcome. The failure rate is acceptable. The rate of sort of donor site morbidity or problems from where you've taken the hamstrings, a few people have the odd hamstring strain and stuff in the first year or so, but longer term problems are quite uncommon. Okay. The second option is patellar tendon with a block of bone at either end. It seems to heal into the tunnels quickly because of the bone. It's a very stiff and strong graft, and it probably has a slightly lower failure rate. So if failure rate's the most important thing, professional athletes and things like that, it may be best option. But you definitely pay for that lower failure rate in terms of higher donor site morbidity. People are more likely to have anterior knee pain, pain with kneeling and things like that, and there's some evidence that perhaps have a higher rate of arthritis in the longer term. Quadriceps has been the sort of big sort of buzz graft at the moment. There's been a few AFL and AFLW players who have had it and have spoken about it extensively in the media. It gives a nice, pretty good solid piece of tissue. You can take it with a piece of bone at the bottom end if you need to get it, if you don't quite have enough length. And some of the early studies suggested that it had really very little donor site morbidity in terms of strength recovery and pain and things like that. However, there has been some data from Denmark recently suggesting that maybe the failure rate's a bit higher than we've expected. So I think the jury's we just don't have quite as much data, unlike the 25 years of good quality data we've got for the other two grafts. So I think they've all got their place, and I would say I probably do about 65 to 70% hamstrings, 25% patellar tendon and 5% quadriceps tendon, depending on patient factors.
Sure. Okay.
Can I ask just a quick question of Tim? I think we'll all see, and I see the same patients you see often musculoskeletally. They're not all high-end athletes. And so I think that prehab is a very, very useful time period to actually, if they have to go onto an ACL, they're going to have a better outcome, a smoother recovery, and there'll be some patients who actually don't require an ACL. But if we're going to go down that path, what do we do about the big effusion, the big hemarthrosis? Do we leave it there? Do we take it out to enable that prehab? What's your thought on that?
I normally wouldn't aspirate them. Normally I just let them sort of settle down. I think the key to it is just to not operate in the bad time. So we've traditionally said if you get them immediately and they're still moving okay, you can go ahead straight away. You don't want to do it while they've got a restricted range of motion. So my thoughts generally are, once you can get to zero extension and once you can flex to at least 120 degrees and your effusion's pretty much down and you're walking okay, I think most of those people are safe to go. And it depends a little bit. There are a few exceptions. There's a few meniscal variants and a few medial ligament variants that might push you into going immediately, regardless of, unfortunately, not being in a favourable position. But in terms of the effusion, I think that's one that I would just usually just let that settle.
Sure. Okay. We'll move on to the second case now. So Sarah is a 15-year-old schoolgirl. She had an acute knee twisting injury at netball on Sunday morning. She's collapsed to the ground and hobbled off the court. She felt something move or clunk in her knee. She presents to your rooms on Tuesday afternoon on crutches. She's got a large effusion and diffuse tenderness. So I'll go to Julian. What are some of the possible causes of Sarah's knee pain?
Well, I think this is one of those situations where you've got a young netballer, similar sort of situation where it could be a twisting injury, large effusion, that clunk. In a young female, you're really sort of almost automatically considering a patellar dislocation, and obviously an ACL is an option there as well. And again, along that line, you then are thinking potential meniscal injury and other also potentially osteochondritis dissecans in that age group with an osteochondral, loose body. But in reality, you're thinking young female teenager, potential patellar instability.
Sure. Are there any specific questions that you would ask in the history?
Look, I think the mechanism of action which you've sort of described is very, very relevant. You'd like to ask whether it's happened before. Often in these age groups, they have a recurring history of dislocation, subluxation, and I think if they've got a recurring history, then that makes you far more likely to consider this as a patellar dislocation.
Sure. Anything to it? Got anything you want to add?
I think before you've made the diagnosis, I think those are the main pertinent questions. Has it happened before?
Mm-hmm.
Sometimes they can give you a pretty good idea of what happened with the clunk. I felt something move out, and then when I was on the ground, I moved, and then it moved back, and that's a very sort of suggestive that it's going to be patellofemoral. Although it doesn't completely rule out other knee instability or meniscus sort of flopping in and out.
Okay. Any specific examination findings that you would try to demonstrate? We're sharing across the panel. Maybe if you want to demonstrate maybe one of you will hold the knee up with a very floppy patella, a lot of ligamentous laxity.
Obviously, the patellar apprehension test is something that you would immediately... Well, the other thing is with a patellar dislocation, they also present with a big hemarthrosis like the ACL, which is why it sometimes can be tricky because it's very swollen. But the patellar dislocators in my sort of clinical practice, they're always tender through the medial side, particularly because obviously
hold it up for the camera.
Most people dislocate laterally and tear through the medial retinaculum and the medial patellofemoral ligament, so they're quite sore here. They've got often compression soreness on the lateral side as well. And I find clinically these people have much denser quads inhibition than the ACL ruptures, in that they just cannot get their quads firing very well at all. And sometimes they do actually rip through their VMO insertion when they do this. So I look at a patellar apprehension test very carefully, but when I'm talking about apprehension, often all you have to do is do this, and you're not even touching their knee and they're already clenching on, and that's a positive apprehension, because apprehension is apprehension. It's not testing to see pain, so...
The other thing about a lot of these patients is that they come to you to see you in the rooms and they've been put in a Zimmer splint by a well-meaning emergency department physician, so they've had 2 or 3 days of getting really, really stiff, and then when you take them out and you want to examine them, they're really, really stiff and they're swollen and they're sore. And in the acute phase, I don't think you get a huge amount of information out of that original examination. They've usually already got imaging, so you can make the diagnosis and things. But it's the examination down the track when things are moving to try and work out surgical planning or non-surgical, etc., which is more interesting, I guess.
Sure. As far as just say we're a bit more chronic down the track, as far as trying to assess for Q angles and patella height and things like that clinically, and do you want to sort of expand on that?
Sure. So a lot of these things, what we're sort of looking at are sort of risk factors for, or anatomical factors that we know contribute to people's risk of having recurrent dislocation. So if you've got a high riding patella, it doesn't engage into the groove until further in the flexion cycle, and you've got more danger time in the early flexion phase. Things like the Q angle, or the sort of amount of the quadriceps has to go around the corner. All of these things are sort of risk factors. They're not particularly, some of them are better physically examinable for, I guess you could say. Patella height and Q angle are sort of pretty rough, sort of end of the bed sort of measures, but things like femoral rotation, tibial rotation, things like that are better judged with clinical examination, ligamentous laxity and that sort of thing.
Okay, so if we go back to the acute setting, what sort of investigations, if any, would you suggest in this setting?
So in the acute setting, I think an X-ray is definitely worthwhile, because these patients do get osteochondral fractures, and an osteochondral fracture is one of the few indications, I think, for immediate surgery. And secondly, an MRI scan, if there's any doubt, will also show up loose bodies and show us a bunch of the anatomical things.
Sure. Okay, so here's a X-ray. I'm not going to use the pointer, but if you look on the lateral X-ray, we can see there's a large suprapatellar joint effusion, hemarthrosis. We can do a sort of in-Salvati ratio, so we can measure patella height relative to the actual patella tendon height relative to the patella bone height. With the skyline view, we're able to get a look at where the patella is positioned, also look at the size of the different facets of the patella, also look at the depth of the femoral trochlear sulcus as well. Are there any other things you're particularly paying attention for on the X-ray? We can also look for a fragment, an avulsion fragment coming off the medial patella as well.
The other thing you can look for trochlear dysplasia. So even though we would think that the 3D imaging modalities are better for showing how deep the trochlear is, the classification system that we use is actually based on a true lateral X-ray. So by tracing the contours of the depth of the trochlear and the different condylar lines, you can actually get a reasonably good idea about whether it's convex or concave and how that looks. I think they're the main things on X-ray.
Sure. Okay. MRI was also performed. MRI in patellar dislocation has a sort of classic appearance. So what we're able to do is look at the bone contusion pattern, which then can tell us what the injury is. So sometimes we get referrals where the patient has an acute effusion and the clinician's unable to examine the patient. The patient's unsure, was there an ACL or a patellar dislocation? So the bone contusion pattern can help us differentiate the two injuries. So we didn't get to see the MRI image, but on that we'll often see bone contusion in an ACL injury of the anterior lateral femoral condyle, posterior lateral tibial plateau, marginal medial femoral condyle. For a patellar dislocation, there's been a transient moment where the patella has moved laterally and has struck against the marginal anterior aspect of the lateral femoral condyle. So these sort of two bone contusions are sort of pathognomonic of a patellar dislocation. The patella then goes back into position, so it's just a transient dislocation. We're also able to show injury to the medial patellar retinaculum and the medial patellofemoral ligament, which comes up here. We're also able to see a chondral defect, so an injury to the articular cartilage. We're also able to see a loose body here in the joint as well. We can see the joint effusion as well. We're also able to see other structures that are intact. So if we move to sort of the management options for patellar dislocation and also sort of okay, so discussing conservative and surgical.
The way I would look at it, the vast majority of first-line patellofemoral dislocations don't need surgery, and I think the exception to that is the ones that have got a loose osteochondral fragment which either needs to be pulled out or potentially fixed back in place. I think that would be the main indication for early surgery. In the recurrent dislocator, I think most people who dislocate once don't go on and have further dislocations, but most people who have two will go on and have more. It's a bit of an oversimplification of the fact that people who have more usually have got other anatomical predisposing factors that often you can identify on their scans and examination. I wonder whether some of those ones, if we know they've got a full hand of problems, whether we should be thinking about operating after the first one. But most of the time, we think that's a little bit aggressive, and we'd give them a run for their money. The problem is that after the first dislocation, you lose your medial patellofemoral ligament, which provides about 60 or 65% of the restraint. So if everything else is normal and you've lost that restraint, then chances are everything else is still normal and you'll stay stable. But if everything else is sort of tilting you towards the edge of falling off, and then you lose your 65% restraint, I think that's when you end up in this sort of recurrent circumstance.
Sure. Julian, do you want to?
Yeah, I'd absolutely agree with that. I think it's one of those areas where a history of recurring dislocation, particularly non-traumatic dislocation, has you really thinking a lot harder about potential, future surgical management. Particularly if you're thinking recurrent dislocation may lead to, even if they haven't got a chondral injury at this time, it will lead to chondral injury and early progressive patellofemoral OA. So if you can identify that recurring dislocator, then that's something which we need to consider. Now, if they're a recurring dislocator and they haven't had other peripheral things assessed, so they haven't really had good physiotherapy in the past, they haven't had distal biomechanics, their flat feet or their high arches assessed by a good sports podiatrist, these are all sort of peripheral things which you can sometimes adjust, which may change their recurring dislocation at the knee. But you do have to start thinking more proactively about how you're going to manage this person long term.
As far as good physiotherapy,
Yeah.
expand for us.
Obviously it's really important to try and get their quads functioning well, but you've got to do it in a position where they feel safe, because obviously full extension is the least stable position of the patella. So I often put them in a little bit of flexion to start with, so that they can get their quads in a safe range. And then obviously you've got to address, what are the contributing factors? Do they have some, poor femoral rotational control? So sometimes it often involves treating the whole kinetic chain, so the hip strength, the calf strength, the quad strength, and a neuromuscular training program, so that it all functions in good alignment together. So it really is a whole lower limb sort of alignment program that you have to go down those lines, and they have to do it for long enough, and some of the things are modifiable, some of them are not modifiable. But also I think it's really important, certainly as physios, that we make sure that we don't try and hang on to people who are not doing well with rehabilitation. And sometimes this is difficult, because I've had patients who are adamant they don't want to have surgery, and they've had recurrent dislocation, and I'm trying to push them towards having a surgical opinion, but they really don't want to. But then by the time they have to really have surgery, they've often got such advanced degenerative changes, then they've got a stable, painful joint, not an... So that's the problem.
We'll just repeat the question. If you just repeat the question.
Oh, how long do I give the physiotherapy? Well, it really depends. I know it's a difficult question to answer. In the acute phase, often it takes at least 6 to 12 weeks to settle the knee down and get it strong and functional. But it depends on how many structural abnormalities they have. Like if they've got trochlear dysplasia, if they've got femoral anteversion, it's much more difficult than that. And also some people have, very poor biomechanics for a long time, so it depends on how old they are, all sorts of things. But they really do need to do a strength program twice a week for the minimum of 6 weeks to get any sort of anywhere near the dosage that you can make any sort of opinion of have they done enough to start with.
Let's say the patient is going to be a recurrent dislocator.
Yep.
They're open to having surgery.
Yep.
You're able to get them to go and see Tim, and if we hand to sort of Tim, what are some of the general principles in surgical treatment of patellar dislocation when you've got a patient who doesn't have significant OA, you've got them early? Can you just talk us through? It's a complex topic, but some of the surgical
So I think the general principles of it is to first of all identify what anatomical risk factors are present in this patient. So what's the shape of their trochlea, what's the length of their patellar tendon, how far across their tibial tubercle sits, do they have ligamentous laxity, do they have strange rotational profile. So you want to try and figure out what out of all these risk factors may be contributing to this patient having recurrent dislocation. Okay, so at least you're considering what anatomical things you may want to change. Then it's a matter of working out what's the sort of correct dose of surgery. most of these people have got all the same anatomical things on both sides, but they've usually got one side that's dislocating and one side that's not. So suggesting that you're going to do rotational osteotomies and all sorts of sort of complicated stuff, that sort of dosage is usually way too high. The majority of people do well with the medial patellofemoral ligament reconstruction plus or minus a tibial tubercle distalization or medialization to correct the sort of Q angle sort of effect. And for the vast majority of people, that's enough. Okay, but there are special cases when we do need to consider things like deepening the groove, changing the rotation, a few other things like that. That's the more sort of extreme end, and it's relatively uncommon.
Okay, thank you. We'll move on now to case number 3. So John is a 68-year-old retired teacher who enjoys gardening, walking, dancing with his wife. He's had long-standing knee pain and a recent increase in severity. This is impacting on his enjoyment of social activities. He presents to you in frustration and pain. On examination, he has a mild effusion and he's got medial joint line tenderness. What are the possible causes of John's knee pain?
So I see John about 10 times a day. Look, I think the pertinent things in that history is his love of gardening, his love of dance. He's a very active guy. He's had knee pain for a long time, and it's only just recently that it's sort of giving him too much grief that it's probably limiting his activities and his quality of life, essentially. So we all look at that knee and that progressive development, and we all understand that this gentleman's going to have osteoarthritis.
Okay. Any specific questions that you would ask in the history?
I think the history and much of the story which Andrew has given is the real pertinent things. What activities do they like? What do they want to continue to do? What have they done in the past? What would they like to do in the future? And I think they're the real pertinent things. Of course, you also got to look at their other comorbidities. How healthy are they? Looking at the options available to them, are they healthy enough to have those options? What things could you explore?
Okay, sure.
I would also want to know what's caused his recent increase in severity. Like, did the sun come out and he spent the last 3 days in the garden, or do you know, like, what is it? Because it might just be a temporary blip, or
has he got a dancing competition? Is there something exactly that he's focusing on? Sure.
I see this man quite a lot as well. And I
think really?
Yeah. I think the other thing
he's seeing a lot of healthcare professionals. Yes.
The other thing I think it's important to ask him, if he's had this pain for a long time, he's probably tried quite a few simple treatments over time. The majority of people that I see like this have not actually had very good sort of non-operative workup, and they've been referred to you, he's got arthritis, he needs a knee replacement, but the truth is a lot of them don't need a knee replacement. What they need to do is go through the sort of a hierarchy of the things that we can offer them before we get that far.
Sure. Okay. What specific examination findings would you assess for? Julian?
Look, there's a couple of things which we really look at. I always like to look at them as they're walking into the room. What's their gait like? What's their stance like? Do they have a big varus sort of angulation or valgus angulation? So I think that's always quite pertinent and gives you a really good indication initially what you're dealing with, and potentially for some simple interventions which you might actually trial. Obviously then when they're actually on the table, you're looking for the effusion. Range of motion's really important to assess. I think range of motion gives you an idea, particularly if it's an acute change in range of motion, whether there's something more acute that you have to consider, say a meniscal injury. If it's a long-standing restriction in range of motion or a progressive loss of range of motion, how does that affect their quality of life and their activities as well? And where do they have pain? You can assess also for stability. One thing when looking at the knee is always look at the hip, because it's not unsurprising. Sometimes you go, geez, this knee examines pretty well, and you look at the hip and it is very stiff, and your movement will reproduce their knee pain.
Okay, very good point. Any other?
Yeah, I've been caught out there.
Okay. Any other examination findings you want to comment on?
I suppose from a physio point of view, there's a few functional tests that we like to get baselines of, as well as all of those things. So I would do like a 40-metre walk test with a time, just as a baseline, so that we can use that to compare later. And also a 30-second sit-to-stand test. So there's normative values of all of these things, and it's a really quick, easy test to do. And then I would have a look at, say, a functional movement as well that he was having trouble with, so I could get that sort of information. That's probably, obviously we would also be looking at muscle strength and things like that too.
Sure.
Yep.
Okay.
Gait as well.
I might throw to Tim. What sort of investigations, if any, would you suggest?
For me, the first and most important investigation for this man is weight-bearing x-rays.
Yes.
And the views are important too. I think he needs a weight-bearing sort of anteroposterior view. He needs a Rosenberg or a Schuss view, which can really highlight, sometimes the AP is normal, but the Schuss view really shows that it's worn, a lateral and a skyline, and that would be the first line.
Sure. And obviously weight-bearing, and often we can do weight-bearing bilaterally as well, and we can also... What about sort of long leg alignment?
So
what's your indication for using them?
The main indication it's more specific indication. So at the moment we're establishing the diagnosis, and the plain x-rays are going to help us with the diagnosis. For me, long leg x-rays are in certain age groups, if we're thinking that if he does have medial disease, that we might be considering a alignment changing osteotomy or something like that, or whether we're considering that he might be appropriate for partial rather than total knee replacement. There's a few parameters that we might look at on the overall alignment which might sort of push us more in one way or the other from some of those more specific things.
Sure. Okay. So here are some x-rays, so we can see this is just an AP radiograph with obvious medial compartment degenerative change. You can see marked joint space loss. We can see the osteophytic spurring. We can also see the suggestion of varus alignment, and we can see a normal x-ray for comparison on the other side. What about MRI? Now, obviously the diagnosis is made, and you could argue the MRI is not required, but...
Yeah, for me, the majority of patients with this presentation and these x-rays don't need an MRI, yes. But there are certainly some times when you might consider it if you are thinking that he might be appropriate for a partial knee replacement and you want to assess the cartilage in the other two compartments to make sure that that's an appropriate idea. If his symptoms if he was having a lot of locking or jamming symptoms and you're wondering whether he might have a loose body or something like that, which is not apparent on the x-ray, and which might change your management plan for him. So there are some indications, but not routinely.
Sure. Okay, so here's an example just of the MRI. So you can see a sagittal proton density MRIs, with the normal shown. So MRI's ability is to show the articular cartilage. So if we look at the normal, you can see the femur above, and we can see the bone marrow, which is white. Then we can see black cortical bone. Then we can see the articular cartilage, which is of that intermediate signal. We can see the black triangles. They are the menisci, which are intact. And then we've got the tibial lining of the joint. If we go over to the other image on your left, you can see that there is significant loss of the articular cartilage lining. We've got subchondral cyst formation, sclerosis. Also, the menisci are degenerative. Now, a lot of those bony changes are evident on the x-ray, but with MRI we can see, for example, here on the left we can see bone marrow edema. Sometimes these patients can have a subchondral fracture. They can get this sort of subchondral insufficiency fracture and may develop osteonecrosis, so we can pick that up on MRI. We can also, as you say, assess the other compartments. We can look for a loose body and other sort of structures. If we move on now to a talk about sort of management options for osteoarthritis, and I think you brought up an excellent point in that rather than just focusing on the knee, we really need to look at the patient as a whole. Maybe between yourself and Julian, talk about some of those issues as far as trialling the different conservative things, looking at the patient's just body habitus, do they have diabetes, all those other conditions before we just focus in on the actual joint. So if you want to discuss that.
Look, I think in reality, what you always have to reflect upon with arthritis is we never treat the x-ray, we don't treat the MRI, we treat the patient. So you've got to look at what are they doing presently, what do they want to do, how healthy are they, and look at the options. And this is not just an algorithm of simple pain relief and then joint replacement, because there's a lot of proactive conservative measures which can be awfully important for patients to consider. And in many ways, even if they go on to a joint replacement, they're going to be awfully important in regards to good recovery and good outcome from a joint replacement. So it's a simple algorithm, and it's something which patients can really consider. So you still do look at simple, pain relief, and there's a lot of broader population-based studies which say paracetamol's ineffective for osteoarthritis pain. But on an individual basis, you will find patients where it can be quite effective and can take that 7 out of 10 down to a 5 out of 10 and make that night pain management reasonable. Obviously, our oral anti-inflammatories we have to be cautious about. Supplements are worthwhile considering. One supplement which probably has reasonable level of evidence behind it is turmeric. You can look at the other supplements such as glucosamine, fish oil, and they're very much hit and miss. But again, I've got patients who swear by them, and with a low side effect profile, I'm happy for patients to trial them. Then you have to consider the things which you're going to have to modify. So you look at their exercise pattern. What are they actually doing? You look at their weight management. And it's a really simple algorithm that I try and explain to patients. For every kilo, there's 2 kilos going through a knee with each step. If they're 10 kilos overweight, they're 20 kilos extra going through that knee, with each step. If they're taking 1,000 steps a day, that 10 kilos equates to 20 tonnes. So I'm asking patients not to lose 30 or 40 kilos if they come in morbidly overweight. I want them to start to lose single digits. If they can lose 5 kilos, that's equivalent to 10 tonnes to the knee at the end of the day. And they will see the difference. And 5 kilos then might lead to 10 kilos. So it's really just taking baby steps. And I think then really looking at those exercise modalities, and Jane can really talk about some of the really great advantages we're seeing with some very good structured exercise programs such as the GLAD program, which is really making enormous difference and really reducing knee replacement rates overseas and hopefully even here. You look at biomechanics. You've got a varus knee, you've got medial OA. What if we shift the load to the lateral compartment, which actually appears pretty good on X-ray? Can you achieve that with a simple orthotic such as a valgus heel lift? All of these subtle, very changeable things can make an enormous amount of difference to people's pain, and that grade 4 OA may not be something which he needs a knee replacement for just yet, and he might make that next dance competition. So we've got to look at all those options.
I tell them it's 5 to 10 kilos worth of force going through the knee. Peak force.
No, I was going to talk about exercise. So there's very good evidence and if you look at the guidelines, they're very broad, aren't they? They say land-based exercise. This is the new guidelines. Weight loss and education. But when you're talking about exercise, it has to be in the right dosage. So this is, again, the problem for many people. They say, I tried exercise. So then you have to say, well, hang on, what did you try? How long did you try it for? Did you actually do a strength program? Did you do it for twice a week? Did you do it for at least 45 minutes, monitored and progressed? And did you do it for 6 weeks? Because if they haven't done that, it's like giving somebody half a Panadol over 3 days and say, oh, didn't it change your pain? So exercise has to be in the right dosage. So Eva Roos is a researcher in Denmark who set up a program called the GLAD program, which started about 3 or 4 years ago in Denmark. And the nice thing about the GLAD program, it's a very structured program which goes for 1 hour. It has 4 or 5 stations. Everybody who teaches the GLAD program has to do a training, like their physios, they have to also do GLAD training. So it's fairly a standardised program, I suppose you could say. And it involves quad strengthening, glute strengthening, neuromuscular training, balance training, a whole host of sort of lower limb strength and control training. And certainly the results out of Denmark has shown that very good results. So they've got a big data collection. So over, I think, 30,000 people in Denmark have participated in the GLAD program. So it's been shown to reduce progression of OA and increase people's, even at 12 months after doing the program, they are still able to do more physical activity and have less pain than what they did before, even though we know the effects of exercise only last about 3 months. But it probably gives people confidence to continue to do more exercise as well.
Can I just comment on the GLAD program as well? One of the things I think is really neat about it, and I think the patients like too, is that it's designed to teach them the principles and then move towards self-management. So if you tell someone with a degenerative condition that you're trying to get them 5 years without a knee replacement and you want them to do physio, they think, well, it'd be cheaper to get a knee replacement if I'm going to have to see the physios once a month or once a week for the rest of my life. But if you explain to them this program is designed to teach you how to do it and the whole thing is geared towards self-management, I think that's a really neat element of the program.
That's a very good point. Julian, I might throw to you. What are some of the options for injection therapy? So,
look, I think there's a number of considerations, and in reality, injection therapy, whilst it may be a conservative measure and can be a very useful measure, it's something which you explore in conjunction with ticking all the other boxes. It's not come in for an injection and that's going to be your answer. You want patients to really understand that treating OA is a jigsaw puzzle, and you want to do all the little pieces, and an injection is not the whole jigsaw puzzle. A knee replacement is not a whole jigsaw puzzle. If you can use these conservative modalities in conjunction, you can get a broader sort of and better complete outcome. Injection therapies, obviously what we have often fallen towards is a corticosteroid injection. Arguably a corticosteroid injection I still use, but it's what I call a honeymoon drug or a holiday drug. It's something which on average typically will achieve 3 to 5 weeks. It means some people get a day, some people will get a little bit longer. There's more recent evidence now that realistically, if we're injecting more than once a year, we're probably going to cause accelerations of people's arthritis. And that's because corticosteroids are chondrocytic, and also the local anaesthetic is probably chondrocytic. There's different corticosteroids which are probably more or less chondrocytic, but arguably you want to limit the amount of times you're doing a cortisone injection. I've done a number of research in the area of biologicals, and in particular platelet-rich plasma. I am a big fan of platelet-rich plasma. I think there is enough evidence now to show that is a good injectable in mild to moderate knee osteoarthritis in regards to 6 to 12 months of symptomatic improvement. It is a good band-aid. When we look at other injectables such as hyaluronic acid, that can also be a very worthwhile consideration. There's now probably 3 brands out there in Australia. There's Durolane, Synvisc and Euflexa, and they all have very similar sort of, outcome results, but typically more 3 to 6 months of symptomatic relief. But there's variability in regards to how much relief people get. But they are band-aids, and there's something to be done in potentially conjunction or always in conjunction with other conservative measures. I think it's worthwhile sometimes to consider in more advanced osteoarthritis. The outcome is far less predictable, particularly in hyaluronic acid. It's something which I probably don't choose to do. You can get a very good result still in grade 4 osteoarthritis with platelet-rich plasma, but the expectations are less in regards to predictability, and that's something which I think the patient just has to be aware of.
And I'd say with those 3 agents, we use, I'm stating the obvious, but we use ultrasound to guide either the corticosteroid, the PRP, or the hyaluronic acid, rather than using X-ray guidance. You obviously can do, some people will do it clinically, just with feel. As far as sort of aspirating the effusion when you're injecting, do you think there's any benefit in doing that?
There's been some evidence that, if you are going to be injecting the knee, aspirating the effusion prior to that is quite useful and actually does improve the outcome. To just aspirate the knee can, potentially be useful, particularly if there's a presence of a Baker cyst. But we know if that underlying driver is still there, that inflammation, that effusion is going to recur, that Baker cyst is going to recur. So again, it's just about what are you trying to treat? How long are you hoping to achieve improvement for as well?
If we throw to Tim now from a sort of surgical perspective, as far as one question will be just discussing joint replacement and sort of the different options and some of the things to consider, and also sort of what's your tipping point to sort of get to the surgical threshold?
Well, I think that point is really, it's very up to the patient. So it's really when the patient tells you, look, I've had enough. Yes. For me, there is an age related, so I don't have a maximum or a minimum age. But the younger you are, I think the more hoops you have to have jumped through, the more I's you have to have dotted, and the more T's you have to have crossed before we consider it. Whereas if you're sort of in your late 70s and you've got bone-on-bone arthritis, well, we maybe don't have to try every single injection before we go ahead. Some of the things that would tip me towards thinking it is when people start to get night pain. I think night pain often is not as responsive as we'd like to all of our simple interventions, and it's also a really sort of it really interferes with people's quality of life when they can't sleep because of that pain. So that's one of the things when you ask a patient, you've got night pain, it aches like a toothache all night, that I'm starting to think about it. But at the end of the day, it's really when the patient says, look, thank you for thanks for trying these other things, but I want to have an operation now. I suppose there's always exceptions. I think the patient with the valgus or the leg that's going outwards, when it's going outwards quickly enough that they say, I notice that it's going outwards, that's the one time that I would try and talk a patient into it, because that's going to get harder and harder to correct surgically, and we should go early.
Okay. Unicompartmental versus total knee?
That's another very good question. I was reading the lay summary from the Australian Orthopaedic Association's joint registry the other day, and they basically said how proud they were that they'd reduced the number of partial knee replacements because they revised more frequently. And I was thinking to myself, if I was appropriate to have a partial knee replacement rather than a total, I'd have one any day of the week. A partial knee replacement, it maintains the biomechanics of the knee. You're just resurfacing one of the compartments. They feel much more normal. It's easier to get over because it's less sort of, damaging and destructive and obliterating, I guess you could say. And, they work very, very well. So for the appropriately selected person, I think it's a really fantastic operation. Unfortunately, only a certain, many people have got pain in more than one compartment or degeneration in more than one compartment, and therefore you're looking towards a knee replacement. But a knee replacement changes the biomechanics of the knee. It doesn't feel like a normal knee, and some patients are very aware of that. And some patients, you look at them, you look at the way their knee moves, you look at their x-rays, and you just think, I can't do it any better than that. And they still say, look, just doesn't, I don't like the way it feels. And that rate's probably around about 10%. And despite all of the advances we've made in materials technology, durability, thinking about how to position the components, it's been pretty static for the last 15 or 20 years.
As far as like patients who have had the knee joint replacement, sort of they're returning them back and how they do after the operation, do you have any comments sort of from a physio perspective?
Well, again, it's that they tend to do better if they actually do a structured rehab program afterwards. It's quite a big operation to recover from, and quite hard for many of them to get their quad strength back, but I think they do better functionally if they can get their quad strength back. So a lot of my knee replacement patients I've sent back to gym programs, and they do very well as long as you select appropriately. And it helps to keep, because often they have a lot of comorbidities, so it's really important. I mean, that's one of the reasons that they've had their knee replacement, so that they can return to activity. So, yeah.
Sure. Okay, we'll move on to the next case, case 4. So case 4, Julie is a 15-year-old student. Netball is a very popular sport, and she loves her netball and also long-distance running. She describes intermittent right knee pain with locking. She recalls no previous episode of trauma. She presents with an acutely painful locked knee, mild effusion, no joint tenderness, and the ability to completely straighten her knee. Okay, what are the possible causes of Julie's knee pain and locking?
Okay, well, in an adolescent who's had a history of pain followed by some, after that, sort of more mechanical symptoms of locking and jamming and now complete locking, for me, the two most likely diagnoses would be, number one, osteochondritis dissecans, where an area of bone and cartilage has slowly been rattling loose and has now potentially come completely loose. The other possibility in this case could be some sort of meniscus pathology, like a discoid meniscus or a not completely tethered meniscus, where it's sort of been moving around for a while and now it's finally flown the coop and it's ended up somewhere where it's not supposed to be.
Sure. Are there any specific questions that you would ask in the history?
I think how well their pain localises. Normally, if this is a meniscus type of problem, they'll tell you the pain was always on this side or that side, and now that's still where it is. Osteochondritis dissecans often has a much vaguer sort of history of pain. They're not really sure where it is. It's deep in the knee. Also, a question of whether it's been associated with swelling and things in the past before this can sometimes help you. But usually the history in these sort of circumstances is relatively vague until you've got in this sort of crisis situation.
Sure. Any specific examination findings you would try to demonstrate?
I think sort of joint line tenderness for meniscal problems, I think, is one thing. Irritability of the patellar joint, if it could be that rarely you can get osteochondritis dissecans, is less common in that joint. In terms of the locking, whether it's just sort of they say it's stuck there, or whether with sort of it's a bit of gentle passive movement you can actually get them moving. But I don't think that there's not really any sort of specific examination test for these things.
Sure. What sort of investigations would you suggest?
I think in this case the acute locked knee with a preceding history, MRI scan is going to be the gold standard for us.
Sure. Okay. obviously there's X-ray as well, gives us an overview. We may see something sort of calcified or ossified. Yes, Julian.
One thing which I do sort of consider in this is if you're thinking osteochondritis dissecans, it's not uncommon that they can have the condition bilaterally. So I do like, to do plain films and just get both knees done. I'd probably just go an MRI on the symptomatic knee, but if there is evidence of potentially an osteochondritis dissecans lesion on the other knee on X-ray, I'd get an MRI of that as well.
As far as the sort of underlying pathology of osteochondritis dissecans, what's your sort of theories on?
Well, it's not really truly well understood. The more recent and I guess acknowledged thought is that it's a history of microtrauma. So it's a repetitive microtrauma causing resulting in an osteochondral sort of lesion. And then imaging findings in regards to whether it's stable or unstable really affects what modality you may choose to use in regards to conservative measures versus surgical measures.
In a group of elite gymnasts at this elite gymnastics centre in Melbourne, actually, last year we had 6 OCDs, 3 in the knee and 3 in the elbow, because we had a new national coach who put in a new warm-up program with triple the amount of tumbling in it all of a sudden. So and this is common in the history, is a increase in load, and a big spike in load, and evidenced by the disastrous outcomes that this,
Yeah, it's poorly understood, but the sort of competing sort of theories are the repetitive microtrauma, sort of a vascular sort of thing, and whether it occurs in a vascular watershed area. There's some suggestion that there can be growth plate abnormalities in that area, and therefore it's a failure of sort of fusion of some of the growth plates. But it's probably repetitive microtrauma in an area which is susceptible because of whatever has happened with in the growth. So probably a little bit of all 3 columns which contribute in an individual to get it.
Sure. Okay, so
how many of those knees required surgery?
None of the knees, but the elbows, yes. The elbows all required surgery, actually, but the knees, I managed several of them, so we just actually had them rest from load until we could see on imaging that there was some healing. And I actually did work with Andrew and get some skeletal age imaging done, so I knew how strict to be with their load restriction, because depending on their growth phase. So, because we know there's more potential when they are still growing, that the OCD could heal, whereas if they've finished growing, they have a much lower chance of healing. Is that what you agree?
Yeah, so whether or not their growth plates are open or closed is the strongest prognostic factor as to whether they're likely to heal with non-interventional treatment or whether they're going to need an operation.
Okay.
So these teenagers who have a fibroblastic defect, could that lead into an OCD or not necessarily?
A fibro
Like a fibrocartilage defect.
in the knee.
Yeah.
I think it would, I said there is something there, but it's not necessarily as fibrocartilage. It's the bone underneath which sort of dies away, and then eventually the cartilage over the top becomes loose from the rattling around.
Yeah, it's a good point you raised, that we often on MRI will see that the overlying cartilage is intact, and it's more a subchondral process which starts initially.
There's a whole bunch of classification systems based on all different imaging modalities, but they're all basically designed to tell you, is this thing mobile or is it not?
And the key is is there joint fluid beneath the lesion, suggesting it's unstable. If we go to this X-rays here, so we can see, if we look at the lateral X-rays, we can see that there's a joint effusion, a suprapatellar joint effusion, compared to the normal side. The actual medial femoral condyle was fine in this patient.
Just before you go on, if you do suspect this, I think again it's important to get that Rosenberg view, because often in the AP view you don't see it, and then when they go into that slightly flexed position, it's revealed on the lateral side of the medial femoral condyle, which is by far the most common site for this.
Yes, good point. This MRI actually shows that a fragment, an osteochondral fragment, has come from the femoral trochlear So not a classic medial femoral condyle OCD, but we've got a loose fragment here with, we can see cortical, or sometimes when the bone dies it becomes sclerotic, so rather than having a fatty signal we will see a sclerotic dead necrotic signal, and we can see cartilage here, so this fragment sitting in the Hoffa's fat pad anteriorly. And we can see the growth plates are still open in this patient, but this is a sort of loose osteochondral injury, osteochondral fragment in the joint. So if we talk about sort of management of a loose fragment,
I think this person definitely needs surgery, and I think everyone would agree. The management options for this sort of osteochondritis dissecans, or where there's an actual loose body in the joint, depends on the size of the loose body, where it's come from, how big the hole it is where it's come from, and whether there's bone on the back of the lesion. So if it's essentially purely just cartilage, unfortunately there's no way to make it stick back on, and therefore you just pluck it out and leave it as is. If there is a little bit of bone, it depends on, sometimes the cartilage fragment's much bigger than the small piece of bone, and again, you're never going to get that to stick back on. A lot of these, my preference if it's a loose body that's not actually refixable is just to take it out, to debride the lesion or tidy it up and then give it a run for its money, because a lot of these people actually do a lot better than you think. The area of cartilage and bone which is eventually rattled off hasn't really been functioning normally for a long, long time, and so often when it's come off with this precipitous event, you pull it out and they actually feel better than they have for a long time. And while there are ways to fill up that hole with sort of fancy techniques of trying to get new cartilage or transferring cartilage from other places or all these things, all of these other operations are starting to get pretty involved, and they've all got relatively significant risks involved, especially considering most of the patients, if you pluck it out, they do pretty well. So my first line, pluck it out and then treat the hole on its merits if it remains symptomatic afterwards.
And often it can just develop fibrocartilage sort of over the top, which we can see on MRI subsequently, which is not high-line cartilage, but is still functionally
Correct.
okay.
And it often does that without doing any microfracture or any other thing which can potentially cause its own issues down the track.
And because this is patellofemoral, it's not a weight-bearing surface, so maybe do better than femoral.
Maybe complain about clicking, but
yes.
yeah.
Okay. We'll move on to the next case. So this is 5A. So Claudia is a 35-year-old personal trainer. She does gym and weights. She's running multiple times a week. She's got insidious onset of anterior knee pain over the past 4 months. Pain with leg weights, squats, going up and down stairs, and she points to the patella, to a region just below her patella as the site of pain. What are the possible causes of Claudia's knee pain?
Well, I would suspect that she had either patellar tendinopathy or patellofemoral pain would be my two main differential diagnoses for her.
Yes, okay, very good. Any specific questions that you're going to ask in the history?
Well, if you go back to her loading sort of thing, she's doing an awful lot, okay? Like gym and weights, F45 and running 4 times a week. And I'd be interested in her loading history. Like, so how long has she been doing this? Was it a sudden spike? Is it, when did the pain start? And, how, and, all of that sort of stuff. So you really need to understand her loading history. And of course you can have coexisting patellofemoral pain and patellar tendinopathy as well. So, it's sometimes not as clear cut as, yeah.
Sure, okay. Any other, Julian, do you have any other points?
No, I'm quite comfortable with that. It's just, it's one of those ones you do see. It's an anterior knee pain. It's more proximal to the patella, or distal to the patella rather. So it really is looking like a patellar tendinopathy.
Yeah, I think these patients, the patellofemoral pain patients, are often like, it's a bit more vague, whereas these people normally say it's right there, there.
Yep. Okay. Any specific examination findings that you would try to demonstrate?
Well, you have to examine the patellofemoral joint to work out if that is involved, and you may do some gliding or some compression to see, and some palpation of the retropatellar sort of facets to see is that their pain, but also palpating the inferior pole of the patella, of the patella where the patellar tendon inserts. They normally leap off the bed with that, and also any sort of loading like hopping or jumping. Yes, that will give their familiar pain if you ask the tendon to actually work like that. Yep.
Sure. Okay. Any sort of investigations you would suggest or consider?
Look, for me, I think if you're looking at the patient and you're considering patellar tendinopathy, I think this is one of those modalities of ultrasound or one of those injuries where ultrasound is probably the best modality. I think MRI at times can overcall tendinopathy. That's just in my experience. You'll find on many MRIs just a deep area of increased signal of the proximal patellar tendon, and they don't have a history of any pain. Whereas ultrasound, I think it's a dynamic test. You can look for other issues like neovascularization. You can look at that hypoechoic change in the thickness. You can compare it to the other side, and it's always lovely to compare a symptomatic side with an asymptomatic side and see a huge difference in the images. It really does correlate with your diagnosis.
Okay. So, yeah, I think Julian's raised a very good point. So, around the knee, but also around other joints, if you're querying tendons, tendinopathy, ultrasound is the first line investigation. It gives excellent spatial resolution and excellent diagnostic information. And if we look here is the ultrasound of this patient's knee. If you look at the very top left image, that's a sagittal image. To the left there, you can see the hyperechoic shadowing patella, so we're not getting any sound coming back from that area. We've put the calipers on a deep area of proximal tendinopathy. So the normal tendon, you can see, has a nice linear fibrillary pattern, so the white and black lines heading down towards the tibia, but that deep area, which is hypoechoic, which is expanded, is an area of tendinopathy. Below that, you can see we've used colour, so we're able to show the actual neovessels. We can show the hypervascularity into that tender area. We can do, and we're able to, and we know that with the vessels are nerves which accompany that area, which cause the pain that the patient will experience. We can also look for a tear of the tendon. Ultrasound around the knee is also very good at looking for Baker's cyst formation. So that's a specific indication, and you can see that image to your right in the popliteal fossa. We can see a fluid collection there. That's a Baker's cyst. So the patient has a Baker's cyst as well. Now you've touched on MRI. So with MRI, these are our fluid-weighted sequences. This is the proton density fat-saturated sequence. And the first image to your left, we can see patellar tendinopathy at this deep surface. We can see that there's edema of the Hoffer's fat pad below. We can see a little bit of bone marrow edema. We can also assess how bad the tendon is. And then those other images to your right show the Baker's cyst, so fluid in the Baker's cyst recess. If we move on now and talk about some of the management, or if we even just talk about, first of all, the sort of pathology of tendinopathy, there are often sort of two patients. There are the patients who are coming from a very low base, and then there are the patients who are doing too much. Can you just talk us around the pathology, and then we'll talk about some of the management options?
I think with any patient, you've got acute tendinopathy, you've got chronic tendinopathy. In many patients, you've got a mix of both, and that's probably affects how you're going to treat these patients. If you've just got that grumbling, slowly increasing discomfort, and you've got that chronic tendinopathy, what you've got to recognise is that tendons like load, so rest per se in a chronic tendinopathy is not going to really do you anything in the long term, as opposed to an acutely aggravated inflamed tendon where a period of unloading is actually really important. So just recognising that history of, is it just this malingering, progressively, slowly increasing pain? Is it something which has been pretty switched on and inflamed, which you do have to settle back down with using potential anti-inflammatories and unloading? Jane, would you sort of consider other stuff?
Yeah, well, as far as a physical management program, obviously we would start off with educating the patient about the pathology and the importance of, managing the load and often reducing the load with this amount of load, because obviously she's doing too much at the moment. And then look at some pain relieving exercises such as isometric exercises, which we often use to reduce tendon pain, like Panadol for the tendon. And then looking at rehabbing the whole kinetic chain. You know, is the calf strong enough? Is the ankle mobile enough? Are the glutes strong enough? Are the quads strong enough? And a graduated program, and looking, you know, at how do they jump? How do they land? So optimising their shock absorption basically through their kinetic chain is what we focus on as physios rehabilitating a tendinopathy.
Did you see any? Do you have any comments?
Not so much about the pathology in the itself and the development. Fortunately, I see relatively few of these.
Yes.
Usually only when they've failed most of the other sort of treatments, which is most of them do well without requiring surgery eventually.
Sure. If we go back to Julian as far as sort of treatment options.
Look, I think once we've identified, that it is a tendinopathy, again, you're looking at patient expectations. What you have to understand is conservative management in a tendinopathy, broadly speaking, will work, if it's very good conservative management, will work 80% of the time. So if patients are willing to, go down that path, then it can be highly successful. You can use additional modalities, you can use dry needling, wet needling. They can sometimes be additionally beneficial in a tendinopathy. And then we can look at, the actual structure. Are other injectables worthwhile? Obviously, fallback in the past was a corticosteroid injection. What we do know is that whilst that can achieve good short to medium term results, long-term results are worse than if we never have done it. So I actually don't use an intratendinous corticosteroid injection at all anymore, and haven't for years. There is probably an argument sometimes if you've got more of a peritendinous sort of inflammation, that you may want to do a peritendinous corticosteroid injection, perhaps along that tendon sheath, but never into a tendon. So there's always sort of considerations in that regards. If you do have that large, hypoechoic area, is it relevant to consider other injectable therapies, other biologicals like autologous platelet-rich plasma? For me, and I do a lot of autologous platelet-rich plasma, I think it is very much overused in tendinopathy. I think it is used for that patient who fails conservative measures, who is not progressing. It is used for that 20% who have not been responsive to good physiotherapy and good rehab. Patellar tendon and Achilles tendinopathy is an area where there's consideration to another injectable therapy, which is a paratenon stripping. And this is a percutaneous attempt at doing what can be a surgical approach at some point in time, whereby you're actually separating the fat pad from the tendon, which has that neovascularization and nerve endings. And that can be very good for symptomatic relief, and you can do a high volume paratenon stripping percutaneously, which can be very effective. And at times, you might consider that for a patient who is unable to progress their rehab because of pain. So all of those things are something which you sometimes think about in your algorithm.
Yeah, the only other agent that we sometimes use under ultrasound guidance is also putting in polydocanol, a sclerosant. So using ultrasound, targeting those neovessels at the deep aspect, not actually injecting the tendon, in the hope that dampens down the pain response. It's not a magic bullet treatment, but it just enables the patient's pain to reduce, so that then they're able to better do their exercise program. If we move on, so Claudia's done very well with her treatment, but she returns 6 months later. She's now got subacute onset of popliteal pain. There was no specific event, but she had a heavy gym session yesterday. The pain extends down into the upper half of her calf, and she limps into the room looking very despondent. What are the main differential diagnoses for Claudia's knee pain?
Based on the ultrasound which you showed up, she had a nice popliteal cyst, so that's what I'm going to go for.
Sure. What about calf strain?
Look, I think all of those things are obviously potentially, you've got a patient here who's doing a lot of load, and potentially there's going to be when you're looking at that anterior chain and injury, there's going to be a degree of imbalance around that knee, and potentially, calf injuries and strains and intra-articular pathology as well.
Sure. What sort of investigations, if any, would you suggest?
I think initially clinical examination is really quite useful. If she's having posterior knee pain and you feel a great big Baker's cyst, then it's potentially going to be from a Baker's cyst. Andrew can go through some imaging, but it relatively sits between the hamstring and the calf, so any knee flexion is going to cause a lot of irritation. But then you've obviously got to think about why have you got a Baker's cyst and do further investigation for that.
Sure. So the ultrasound shows that the collapsed Baker's cyst, we may see edema and fluid tracking down the knee. We sometimes also get patients just coming for MRI as well, and we can see the Baker's cyst. We can see free edema tracking down the calf as well. So often we get patients sent for Baker's cyst. What's the management of the Baker's cyst? How are we going to get rid of this Baker's cyst? Why is the Baker's cyst coming back? If you want to sort of maybe work our way across the panel, but what's sort of some of the...
For me, most often the Baker's cyst is a symptom of whatever the real problem is rather than the real problem itself. So there's usually a small communication between the knee joint proper and the popliteal cyst, which acts a bit like a ball valve, so fluid can push through and then it can't come back. So it's normally what's driving the fluid generation in the front of the knee to give you your Baker's cyst, rather than how do we manage the Baker's cyst. So normally I would take a history and examine them, looking for things that might cause fluid in the knee. Typical things are meniscus tears or chondral pathology, that sort of thing, and I'd investigate them based on that, and I would aim to treat the cause of the symptoms rather than treating the what I consider to be part of the symptoms. That said, we don't always find an obvious reason in the front of the knee, and in those circumstances it may be worth considering trying aspirating and injecting the cyst. But a bit like the tendinopathy is probably about, it doesn't work all the time and it may be recurrent, and if it is recurrent, then we consider how we go along the algorithm all the way down to rarely doing an actual open incision and trying to close over the hole from the back, but that's pretty uncommon.
Okay, so here's just an example of the Baker's cyst. Here's our needle coming in. We're able to aspirate the cyst, and then we put in the say celestone, a bit of xylocaine into the cyst, a remnant. Okay, so we've got a question here.
Just with the Baker's cyst, what further complications if you get a rupture of the Baker's cyst do you have to then consider and deal with?
Often when they rupture, it's acutely painful for a short period of time, but then often that discomfort, if they were getting symptoms from having the cyst in the back of their knee, often resolves, and it sometimes never comes back. I don't think there's any particular sort of treatment or required for that.
You just go, yay.
Yeah, well, we hope that that's going to be their one-off event and then it settles down, because they no longer have this encapsulated sort of collection there.
Sure, okay. Now, before we wrap up, any final questions without notice for our panel, our esteemed panel who are here?
A question about injectables in OA. In my 3-year-old, if you could answer on in a 93-year-old woman with a long history of corticosteroid use and deterioration, in terms of pain and initial pain and swelling, which would you say is better indicated? Would you say the PRP, or would you say the Cyst is better?
So maybe we'll repeat the question. So 93-year-old with OA has had multiple corticosteroid injections into the knee joint. The question now is, should we go down the PRP pathway or should we go down the hyaluronic acid injection?
Personally, I don't think there's much in the evidence base to suggest that one's better in one particular circumstance. I think they're both sort of ideally in that sort of mild to moderate and don't work quite so well once you get to the sort of bone-on-bone sort of arthritis. I think then it's a bit of a coin toss. In my experience, the hyaluronic acid injections seem to work quite well in patellofemoral degenerative change. So if her pain or her symptoms are predominantly patellofemoral, I'd consider that first. And in the back of my mind, I also sort of think, well, PRP, we sort of think that it works by helping the cartilage, and you sort of got to have some cartilage there for it to help. So if they're sort of bone on bone and we're really clutching at straws, I tend to try hyaluronic acid first and then PRP second, but that's not based on good scientific evidence.
Another question?
early clinical examination that might, this is more for the boys, that might suggest an ACL rupture in a knee might be appropriate for the rehabilitation approach with Jane, or let's just do the surgery immediately. So for example, if it's a really loose ACL or a multi-directional unstable ACL assessment, do you think let's just operate on these because they won't respond to a prehab? Is there any indicators that make you think surgery is appropriate or not?
So the question is to whether there's any indicators to suggest that early surgery versus delayed surgery for ACL, any clinical indicators, is that?
Well, if we get to functional instability, do you have any early signs of clinical examination that will lead to more functional instability later?
It's a good question. For me, I think most younger patients are already thinking along the lines that they're going to have a reconstruction. And I think people in their teens almost always should have one. People in their early 20s, most of them are going to want one anyway once you've discussed with them the sort of pros and cons. In terms of examination findings that might lead you to an early reconstruction, I think it's more examination findings that might make you want to wait. So patients who are really stiff and swollen, you're going to want to wait. If they've already got a good range of motion early on, I don't think that the amount of actual clinical instability is a good indicator of whether or not they should have early or late instability. It may be an indication for whether we consider some of the techniques we've been talking about recently, lateral extra-articular procedures or things like that. So if they've got significant rotational instability, we may be thinking along those lines, or if they've sort of hyperlax and that sort of thing. But I don't think it necessarily affects the timing of surgery. I think the things that would push you towards acute surgery are sort of repairable or locked meniscal tears, and some variations of medial ligament injuries I think should have immediate surgery.
And your multi-legs, obviously. That's a different, yeah. But interestingly, you do see sometimes over time, people's Lockmans do tighten up and their pivot shift does also tighten up. And I've had that with a few patients who've then become, I suppose, what you call copers, who have an ACL deficient knee, but they don't have functional instability. And I have seen that their clinical exam has changed over time. And that's certainly documented in the literature as well. And in fact, we've had 3 this year that have MRI evidence of healing. So it does rarely happen, but it does sometimes. Yeah.
Yes.
And just while we're on the ACL topic, more specifically for Tim, your indicators with partial thickness tears and when you decide to operate or not in the young group.
I think partial thickness tears are actually pretty uncommon, and I think when you examine these patients, they usually feel like they're really gone or they feel like they're not gone. And so I tend to base it more on what I think the clinical examination's like. The MRI findings, sometimes it looks like it's a partial rupture, but when you go in, there's a few tendrils sort of hanging on, but the bulk of it's sort of really ripped off. And I think that I think the proper sort of partial rupture is actually less common than we sort of make out.
Okay, so that brings tonight to a conclusion. Oh.
Going back to the 93-year-old, the other half of the question was in terms of payments by the initial payments by which one is better indicated
Look, there's been a number of trials which have assessed the difference between hyaluronic acid and platelet-rich plasma, and some have said in regards to medium to long-term, fairly similar. Others have suggested, and these are usually more looking at moderate OA, are more considered in regards to PRP having better longer-term efficacy and greater efficacy. In regards to the flare-up and the tolerability of the injection, look, I think when you get a really big synovitic knee from hyaluronic acid, you're a bit scared off of doing it again. And I know I've had that experience, and you sort of have that late night phone call of a horrible swollen knee, and then you have to see them and aspirate and do a corticosteroid injection. Sort of, it makes you shy away from it. Platelet-rich plasma is typically very well tolerated. You do tend to find that they may get a dull ache for 1 to 2 days. In probably 10 years of use of PRP, I've probably had half a dozen patients have a significant flare-up, which may last 1 to 2 weeks. So again, that can occur, so you always have to tell patients to be prepared for it. But usually responds well to a period of icing and will settle down. So I think PRP, in my experience, is probably typically better tolerated. That said, some of the new hyaluronic acids, which are a single injection, not a triple injection, are probably less likely to be associated with that synovitic flare.
So the original hyaluronic acid, which was Synvisc, is derived from rooster comb protein, and some people had a really strong immune-mediated response to that, and that's what you're talking about. Of the synthetic ones, Durolane, it is occasionally has been reported, but Euflexa and Monovisc, which are the two most recent onto the market, it doesn't really happen, I don't think.
So any more questions, you can come up to our panel at the end. If you're a GP, you must fill in the rating and assessment form and hand that in to... yes, but that has to be handed in to Julie and Tanya so that you can get your accreditation. I'd like to thank Jane Rooney, Tim Lording and Julian Freitag for coming along tonight. Tonight's video...